open really well. So this is where we can see the gap. This is the gap which has been opened. We can use a lamina spreader also as an option. But the problem is, like the previous instrument, with the distraction on, the osteotomy is completely open and you can insert your graft easily. While here it's a bit difficult because lamina spreader is in place and it does not allow the bone graft to be pushed easily. So once we have taken the graft, we can measure the distraction. Accordingly, we take a graft from iliac crest. I use in a lot of patients the fibula. I take a segment of fibula and then divide it into two pieces and try to fill that in the gap. So with the help of punch, we insert the graft completely, and then we extend the, we push the wire which is already there at the osteotomy level. We pass it through the graft and then in the proximal fragment of the calcaneum. Take IITV views and ensure that it is properly in the calcaneum. So graft, already we discussed that these are the options. Particularly in cerebral palsy, if you are doing as a multi-level surgery, then a lot of times we use distal femur osteotomy as a technique, distal femur shortening osteotomy. So the same fibula can be used as a graft to fill in this osteotomy. We may not need to take a separate iliac crest graft. This will work. Fixation, usually the K-wire are sufficient. I don't go for a complicated procedures like fixing the plate. In literature, you will see a lot of patients, they are using plate and screws. But I'm very happy with two threaded K-wire, which is giving a sufficient hold. Staples can be used, but fine. As I said, that I'm very happy with two K-wires. Now coming to the most important thing in cerebral palsy, this deformity has taken place because of the imbalance between the everter and the inverters. So once we correct it, the medial column will become lax. And on a medial column, there is an inverter, that's a tibialis posterior. So we need to shorten them so that the balance is created. That's the additional procedure which we need to carry out in cerebral palsy. So we shorten the tibialis posterior. So for that, we are looking at the medial side of the foot after correction. We make a small incision along the tibialis posterior, identified around 2 to 3 centimeter of tibialis posterior. And then we use a technique which I will explain you. If this is a tibialis posterior, we use a strong artery forceps like this, and then we rotate. So what happens, the tibialis posterior will enroll on the artery forceps and will become tight. So after rotating around say like 360 degree, there will be a shortening or the plication of the tibialis posterior. We keep that artery forceps in that position and take a suture and plicate it. We don't cut it, we just make it short, because our aim is to shorten it so that the extra length of tibialis posterior is taken care of. Now coming to the most important point, after the foot correction, we need to look at the length of the calf. We carry out cerebral skull test because always there is a shortening of the calf, either gastroc alone or both. So we carry out that checking after correction of the foot. Don't do it before, because unless and until you have corrected the foot, you are not going to assess the the calf properly. So at this stage we carry out this correction. And now the most important thing is, like, once we have corrected this, we need to take care of the supination component. So I will explain you that part in a details so that you understand the concept of that. So now we are looking at the foot from behind. We have tibia, fibula, talus and the calcaneum. We understood that hind foot goes into valgus. Now before that we have a metatarsal with that. So what happens when hind foot goes into valgus like this? the forefoot also rotates with the hind foot. Right? So something like this will happen. But patient cannot walk like this. So gradually what will happen? The hind foot will remain in valgus, but over a period of time the forefoot will twist and will get corrected like this. Right? So now the compensation has taken place in the forefoot. Once we correct the hind foot and we have corrected it, so now the forefoot will follow and will go into a supination. Right? So that's very important, that in a long-standing cases, this is one of the component, and if you don't treat adequately or properly, then patient will go for a relapse. So this is one of the things that you have not corrected, one of the component of the deformity. So either we can use a wedge, but before that, this is what the picture at the time of surgery. Now look at this foot very carefully. The deformity has been taken care of. We are looking from top. This is long axis of leg, and we can see that this is what the forefoot is. It's in supination. So if we don't correct it, then child will be having a good heel contact, but the forefoot will be remaining like this. So for that, if you are not comfortable with the osteotomy, then you can put a wedge insole. This is one thing, that you give a wedge sole on the forefoot, because hind foot is well corrected. Please remember that if you don't do it, you will lose the correction at hind foot also in next few years. The better option is to go for a surgical correction, and for that we have a very simple procedure, that we cut the cuneiform bone and bring it down. So we bring the first metatarsal down, and for that let us understand this concept. We are looking at the foot from side, from the medial side. As we saw in this picture, the first metatarsal is higher compared to the fifth. So now if you look at the first metatarsal is higher, it's not touching the floor, while the fifth metatarsal is touching the floor. So what we do, we cut a wedge-shaped bone from the plantar aspect and we bring it down. It's just a small simple procedure, and it corrects the forefoot alignment. We can fix it with K-wires. We can make a small staples out of K-wire and then fix it. So this is how, this is per-operative picture where we take out this wedge and then we fix it. And now you can see that this forefoot is also aligned with the leg. This is long axis, now forefoot is perpendicular. And this is after fixation. Here it has been fixed with a small staple. You can use K-wire also. Post-operative management, once you have done surgery, now it's just a simple routine thing which we do, below knee cast. If you have done tendo-Achilles lengthening or any procedures at that, we may extend it above the knee joint. So if we have done a calf lengthening, then we need to give above knee cast. We keep them non-weight bearing for 8 weeks, check x-rays at the time of removal of implant, and then we give a plastic arch support so that the abnormal loading can be prevented and the foot shape is maintained, and that we continue for 1 and 1.5 years. We are not going into the complications because on one side I am trying to do the procedures, and so I don't want to make you afraid of that. But very rarely I have not seen a non-union subtalar fusion by iatrogenic extension of the complication. You can do that. Under correction is one of the things, because we are not really strong or like confident in lengthening the foot, and we may end up with under correction. So the take-home message is lateral column lengthening improves the biomechanics, and definitely it helps us in gait improving. Plano valgus has a 5 component. The 4 components are very easy for you to understand, but the forefoot supination is the 5th component which we tend to neglect and don't operate. All components needs to be dealt with. Then and then your foot will remain stable for a period of time. And please remember that this surgery has a limitation. For a severe deformity, it does not work. So in that case, we need to go for more extensive procedure like triple fusion. So with that, I wish that you are able to do this procedure confidently. If you have any question, please take this presentation from Jaswinder, or if you want to see a video, please let me know. I will share that video with you. Thank you.
More posteriorly in the calcaneum and do a varus and a translation.
So something like the
One
displacement
part of
osteotomy.
yeah.
Okay, so this is basically is correcting the deformity at the subtalar joint. So this is not a compensatory deformity, it's a correction deformity. While the one which you are talking, which Sandeep also discussed and I also discussed in the previous lecture, we are not doing anything at the subtalar joint and we are compensating the things and then we are improving the things. So the subtalar joint remains in an abnormal position, but we are correcting it three-dimensionally. Yeah, extra-articular.
In the words of Moshka, the calcaneal lengthening osteotomy is a Salter osteotomy, whereas the calcaneal displacement osteotomy is the Chiari osteotomy. It is like a salvage.
That Dr. Mosca says calcanopedal block, and he always describe it like that. Actually, what he
You should call it the Bernese osteotomy.
Because he explains on acetabulum pedis that concept actually. Wonderfully presented by Dhiren sir, and it's time to felicitate our chairpersons. Dr. Hitesh sir, please do the honors. Dr. Dinesh sir. Dr. S.P. Gupta sir. And Dr. Ravi Shankar, please. May I also let everyone know that whatever lectures and the whole course is being also streamed online on the Ortho TV. So if someone has missed something and he wants to go back and see, everything is available on the Ortho TV. So we are recording it. We'll take a break now for 10 minutes. It's for a small tea or whatever you want, and then we'll come back for our last session, the theoretical session. Thank you. May I start with our last session, which is after that we'll be starting with a hands-on workshop. So for the chairpersons, may I invite Dr. V.K. Sinha sir, please, on the dais. Dr. Rajat Charan sir. Dr. Praveen Sahu sir. And Dr. Chandan Soni sir, please. And the next speaker is Dr. Saurabh.
Starting with the miscellaneous session, and Dr. Saurabh Chaudhary will speak about the child with foot pain.
So the topic allotted to me is approach to a child with foot pain. That's a very broad topic and it encompasses a lot of disorders. I'll not be talking specifically about trauma cases, that has been covered, and also about majorly about the deformities that I think we have discussed at length yesterday. We'll be discussing about certain case scenarios which are less commonly seen, but being pediatric orthopedic surgeons or being orthopedic surgeons, oftentimes we are referred cases by the pediatricians because the patient predominantly has a musculoskeletal complaint. And it's good to know, sometimes necessary to know which cases are pure core orthopedic cases and which cases you need to refer or work up in a different way. So non-traumatic causes of foot pain are like many. There's a huge list, and if at all you are faced with a patient who complains of foot pain, you may have a mind-boggling list of conditions which come to your mind. But in any case scenario, what we automatically do is we try to categorize that particular patient into some kind of etiology. And it's useful to know the conditions which are I mean, arranged in categories based on the cause of the problem. So these are the various etiologies which may present with foot pain. So the history sometimes, if it's a young child, the history is non-existent. You have to rely on the history of the parents, which may or may not be very useful, and often it is garbled. We have to make sense of what they are speaking, separate the grain from the chaff, and try to make sense of what the real issue is. So going to the history, there are a lot of questions that we need to ask. Onset of foot pain, any specific injury which was there, location of the pain in the foot, is it involving one side or both the sides? What kind of pain is it? What kind of factors aggravate it or relieve it? Any swelling or redness or warmth has been noticed by the parent? How does it impact the daily routine or the play? Any foot problems in the past? Has he had any similar issues in the past? How is the pain in the morning or the evening or the night? And how does it respond to analgesics? And if there are any systemic features are there like fever or abdominal pain, any other joint swellings, any family history, and loss of appetite and loss of weight. So basically from all these questions we want to ascertain whether this is an acute issue or a chronic ailment, whether one or more joints are involved, and if there are systems other than joints which are involved. So these few questions you should be able to answer by the end of the history. And how severe or significant it is. Usually the children will like to play. If the play is affected, then you understand that the problem is significant and you should be prepared to investigate further, even if the lab investigations and x-rays are normal. Examination begin with general condition, whether the child is sick looking or looking active. Always check for pallor, rashes, skin lesions, nail changes. You look at other joints proximally. You look at the upper extremities and the spine. You look at the gait of the child, standing and sitting alignment of the spine, and the Beighton score. Locally, we look for swelling, redness, sores or callosities, overall shape of the foot, and any undue prominences if at all present. The foot is largely palpable, which is a good thing. So it's very useful to know the surface anatomy of the foot, where all the bony prominences, what all bones they represent, which tendons they represent, and if needed, we need to activate those tendons and stress them and check whether the tendon is painful. Labs usually in a typical case are not very useful. Routine tests, CBC, ESR, CRP is always done, occasionally vitamin D and alkaline phosphatase. Selective cases based upon the history or the kind of presentation that a person has, you may have to do antibodies, ANA, HLA-B27 and other markers. Imaging, again, X-rays are essential. Other imagings are required in particular cases. So this is a very didactic approach to what we we may discuss academically, what causes can be there, what history and examination and all that. But in clinical practice, we don't go by this approach. We usually try to fit the patient into a particular kind of clinical scenario and then do a selective examination and selective investigation. And if at all we don't get an answer, then sometimes we go back to the examination and labs again. So I'll just discuss briefly about certain clinical scenarios which are not discussed in pediatric orthopedic meetings or general orthopedic meetings. The first is the inflammatory arthritis. GIA or various other conditions are labeled into this. This is usually a child who has pain for more than 6 weeks. One or many joints may be involved. There may be significant early morning stiffness. Now the child or the parent will not be complaining of stiffness in the morning. What they will be saying is the child does not, is very reluctant to get out of the bed in the morning, and it takes about 1 to 1.5 hours for the child to be more active or start playing and all that. Occasionally the child may have some abdominal pain, his sleep may be disturbed, he may have rashes, fever, red eye or burning micturition. So child is crying while passing urine, or any history of these kind of loose motion or burning micturition in last 2-3 weeks. Labs may show a moderately high acute phase reactants. RF anti-CCP typically not very useful. ANA occasionally is raised, and HLA-B27 is occasionally required. So I must emphasize it's a diagnosis of exclusion. You have to rule out other causes or more significant or severe causes like infection before you label a child as a case of JIA. Child with rash and abdominal pain, think of HSP. Child with rash and sick looking child, he may be having Still's disease. So these are just some things with you need to bear in mind. And JIA can present with multiple clinical pictures. So it may be a pauciarticular, it may have a picture similar to adult onset RA. It may be having systemic features, it may be associated with enthesitis or spondyloarthropathy kind of picture. The second clinical scenario is infective. Usually the symptom duration will be very short, accompanied by fever, and child is refusing to bear weight. This is something that we need to, we should be alert that it may be indicating infection. There will be swelling, redness, and localized tenderness, very high ESR CRP. X-rays may be normal in the initial stage. You may have to resort to ultrasound or MRI to get the diagnosis. And usually the foot is not a very common site for septic arthritis. So if at all you see any sepsis which is there localized to the foot and it's not secondary to some thorn prick or something, then you must think of immunocompromised status. You may have to rule out systemic infection, endocarditis and other things. Neoplastic is another broad category. Usually the pain is of weeks or months duration. Pain is constant and progressive. So pain is unrelenting, or pain is always there. It's not like some days the patient is fine and some days the patient has severe pain. Location is fixed. X-rays may be normal in the initial stage, but if the pain is persistent and it's on a fixed location, you may have to opt for advanced imaging even if the X-rays are normal. Counts will be normal. Alkaline phosphatase and peripheral smear are sometimes required if at all we are suspecting systemic features also like back pain and loss of appetite. Especially leukemia. Leukemia can present with foot pain, leg pain or back pain. So that is something that you need to bear in mind. Child will be sick looking and he'll have some back pain and he will be referred to you from the pediatrician. Always bear in mind it may be something else. If the counts are low or the peripheral smear is showing some atypical leukocytes, that clinches the diagnosis. Certain localized bone tumors, Ewing sarcoma, giant cell tumor of the tendon sheath, these are all possibilities that you have to bear in mind if the problem is in a specified location and the pain or the symptom is unrelenting. Now often growth related pains are very commonly presenting to our clinics and sometimes they are overdiagnosed also, but it's useful to know what the typical patient is. Typically the patient will have pain in the legs, very less commonly in the foot, and it will be episodic, severe pain. Child will be crying in the pain, especially in the night, or it is worse on certain days where the activity has been more. And he will be absolutely fine in between the episodes. So this is something which tells you that it is growth related pain, because between episodes the child should be playing well, eating well, sleeping well. There should not be absolutely any complaint in between the episodes. Overuse injuries, again the history will probably tell us that there is a recent increase in activity or certain specific activities have started. Issues with footwears, specific site, again, and if you examine, usually you will find a spot as a tender spot and usually it responds very well to a brief period of rest. Always check for Beighton score in these kind of patients. Osteochondrosis again is a very broad category. Usually again it's a diagnosis of exclusion. The site will be specific, it may be related to activities, no inflammatory signs will be there locally and it usually responds very well to rest. There are many of them described, but the commonest ones will be Sever's disease, which is in the calcaneal apophysis, Iselin disease which is there in the base of the fifth metatarsal, Freeburg's occasionally in the second, third or fourth metatarsal heads, and Kohler's which is of the navicular. They all respond very well to a brief period of cast or immobilization. So the take home is, if at all there are more than one joints involved, always look for rheumatology consultation. If there are systemic features, refer back to the pediatrician or get a pediatric consultation. Always differentiate arthritis from arthralgia. And if there is a persistent one joint or one region pain, try hard to disprove infection or neoplasia. You may have to opt for an MRI right away if the pain has been there constantly and the patient is in significant agony. Thank you.
Thank you broadly elaborating the painful foot. Next speaker.
Dr. Hitesh Shah. He'll be speaking on postural deformity of the foot.
Yeah, good morning. After we have this talk should be the first rather than the last, but not the least. It should be discussed. So, why it is important to understand about the postural deformity of the foot? Because we need to differentiate between the is it actually the benign postural deformity or is it the pathological, or we are missing some pathology. So, the today's the foot and ankle, the deformity of the postural deformity is very common to have a calcaneal valgus, metatarsal adductor, or a postural clubfoot, or it will be also having in case of the children, as yesterday we discussed, the flexible flat foot. These are the very common deformity. So, what is needed? What the orthopedic surgeon or the trainee or the pediatric orthopedic surgeon should know about that? There are the common deformity and how to differentiate from the physiological from pathological. That is the main part, because the name itself says a postural means it's just required benign observation. It's just required to have a serial follow-up. So, what is needed for the deformity? As I said, there are three common deformity. It's a calcaneal valgus, that is a talipus calcaneal valgus, the postural clubfoot, or sometimes it's a metatarsal adductors, and the plano valgus due to ligamentous laxity is very common in the children. So, these are the three different heading I am going to talk on that. So, first let us start with the calcaneal valgus. What is a calcaneal valgus? When the child is born, there would be full dorsiflexion of the ankle present. The tibia and foot can be touched together. So, if the orthopedic resident or even the orthopedic surgeon would be called from the NICU, when such and such child has been born and there is a deformity of the foot, first question we need to ask, is it benign or is it a pathological? Whether it's a benign means, is it a postural calcaneal valgus or is it something different? So, very commonly we can have a differential diagnosis is the vertical talus or the congenital posteromedial bowing, or it will be having in few cases of the fibular hemimelia limb deficiency, where we can find out about the postural or the benign or actually pathological calcaneal valgus. How to differentiate between the both? Whenever there is a deformity is at ankle, it will be passively fully correctable. If we can bring to the neutral or overcorrect, it is most likely to be postural. Second, there are all toes would be present. Like if you see in this child, all 5 toes are there. Any ray of missing, any ray, whether the medial or lateral ray, it will be always associated with the limb deficiency. So, it will be fibular hemimelia or any other deficiency. And the third also important, the bowing of the tibia. Where there is a tibia is bowed, very commonly the postural, I will show you the photographs on that. There is a tibia is bowed, then there would be associated like a posteromedial bowing. Why need to differentiate between postural and that? The natural history of the postural deformity is very, very different than the other part. So, as I said, the first and foremost, you need to bring that to the neutral. If you can bring back to the neutral or the overcorrect, it would be postural deformity. It will be all the crease would be around the medial side, lateral side, multiple crease would be present. Do not forget to examine the hip if you have the ligamentous laxity or the associated with the calcaneal varus or metatarsal adductors. Always examine the hip, okay, because most of the time you are called to see about the foot deformity, but you need to examine about the hip and spine. Why? Because that may be the secondary to the spinal deformity or the spina bifida. So, always examine the spine then the hip before labeling as the postural deformity. Then the pathological, when there is a calcaneal valgus is there, there would be rocker bottom. Yesterday we have discussed the full, but always see about the sole and see whether it is the plano valgus or is it rocker bottom foot is present, is differentiate between the vertical talus. As I said, if the ray is missing and going in a calcaneal valgus, that would be associated with the fibular hemimelia very commonly in plano valgus foot, or it would be associated with the bowing. If you see the bow, there is the bow, the medial apex and the posterior apex, that is called as the congenital posteromedial bowing of tibia. That are the three important differential diagnoses between the calcaneal valgus. What is required? You need to keep in the observation, passive stretching, and few case, extreme case of the calcaneal valgus will require about few cast. There will be the few cast like a clubfoot. You need to stretch for the couple of weeks and just go about observation. So, whenever doubt, you have to keep this child into the follow-up. Second entity, the postural clubfoot. So very, very common we can see about the clubfoot because of the package is that you see there is a mild forefoot adduction is present. But what is different between the rigid clubfoot or the postural deformity will be different. Full dorsiflexion would be present and there would not be any spurious correction like we see yesterday. There is the hindfoot equinus is present where the empty heel sign is present. You can see about the multiple crease across the ankle on the posterior aspect. Number one, you cannot have empty heel sign, and the third, full dorsiflexion is possible. These are the three important marks that you can differentiate between the postural clubfoot and the rigid clubfoot. So if you see that multiple creases are present, there is a looks like the forefoot adduction and the varus. But if you can do about the dorsiflexion, patient can able to passively, it can be brought under the overcorrection on the either side, the both side. So you can see there is the postural deformity, not actually the rigid deformity. Another example, there is looks like the cavus is present, so there is a equinus, but we can able to do about that. It's a good amount of the dorsiflexion is without doing any casting, the first presentation. So there is a difference between the rigid clubfoot and the postural clubfoot. All the component would be present and that would be rigid, not passively correctable in rigid clubfoot because deformity is in the postural. It is not correctable at all in case of the rigid clubfoot, while it is fully correctable in case of the postural clubfoot. And the third important differential point is that the multiple crease would be present on the posterior aspect than the deep posterior crease is present in case of the rigid clubfoot. Why we need to differentiate? Because the clubfoot is a spectrum of deformity. It starts from the postural to rigid. It may be also having idiopathic or a non-idiopathic, is having spina bifida to having multiple congenital or multiple syndromes. That is a multiple syndrome. And before labeling about the postural clubfoot, you need to do about thorough examination of every single system. Okay, don't say we have learned that passively it's correctable, that means it's postural clubfoot. Always examine the all other system before say labeling as a postural clubfoot. And one important example, the last week we have seen the child like this, it's labeled as a postural clubfoot, but it is actually the case of the severe sacral agenesis. This is a type 4 Renzo type where lumbar spine is, the lumbar L4, L5 is missing and different part is also missing. And thorough examination is needed to find out the prognosis of this child is different. It doesn't require serial manipulation and casting because child is not having the neurological intact. It's the lower of the, it's a Buddha-like position is not getting corrected, and unlike to get it changed with the plaster or any other intervention. But in short, the postural clubfoot require just manipulation by the parents, and few cases where deformity is persistent after few weeks it require about the casting, but it doesn't require about bracing in long term. The third, that's the pes planus. Yesterday it is described in a great detail like a flexible flat foot. The Sandeep has described into that. So I am not going quickly. Why you need to know about the flexible flat foot? Because it may be varies from the cause to cause, including hyperlaxity to tibialis posterior dysfunction, or sometimes because of the obesity, and it may be also a pathological in terms of the tendo-achilles contracture, the subtalar coalition or a tarsal coalition or accessory navicular. So we need to check about the laxity, whether patient has got gross ligamentous laxity, whether the child is having obesity, or because of the shoe wearing technique, whether the child started use the shoes very early. Yesterday, Sandeep has described about Jack test will differentiate between the flexible and rigid, and then another test is the toe weight bearing, where the tiptoeing the arch is appearing. That is a flexible flat. So actually, they consider it to be as a physiological. But always examine the ankle. There is a limitation of the dorsiflexion. Give idea about the tendo-achilles contracture. Always examine the subtalar. The mediolateral, the inversion and eversion, if there is range of motion is restricted, give idea about underlying the tarsal coalition. Always examine the metarsal. If metarsal is restricted, it will give idea about that tarsal coalition in metarsal plane. So I'll conclude my talk in that we must differentiate between the postural deformity with pathological. Always rule out the pathological before labeling at the postural clubfoot, and it's necessary to detect this postural clubfoot or a postural metatarsal adductors or a postural calcaneovalgus or postural flat foot, because that will lead to the unnecessary anxiety to the parents. Thank you.
Would you like to continue with the
Office orthopedics will continue with the conditions that we see, the common OPD conditions, and idiopathic toe walking is another common condition that we see. So this is a brief outline. First I will talk about the definition of idiopathic toe walking. When should you label a child as an idiopathic toe walker? What is the natural history of this if left alone? And if at all you need to treat, then what are the various treatment modalities with their outcomes? So what is idiopathic toe walking? So it is a true equinus gait, meaning that the ankle is in equinus. The initial contact in the stance phase, it is on the toes rather than being with a plantigrade foot, it is on the toes. And all three ankle rockers are affected. The most important point is to label a child as an idiopathic toe walker, you have to rule out any underlying pathology. So it is idiopathic in an otherwise healthy child and it is a diagnosis of exclusion, which means essentially that you have to examine the child as a whole. You have to examine the entire neurological system, the musculoskeletal system, and you have to rule out underlying cerebral palsy, Duchenne muscular dystrophy. Autism spectrum disorder is one condition which does give rise to toe walking, and here it's a very troublesome and very frustrating condition to treat, toe walking in an autistic child. Here the cause of toe walking is sensory disturbances. So what happens is when the child places his entire foot on the floor, he gets lots of sensory impulses, and to avoid those sensory impulses, the child is toe walking. This can be a bit of a frustrating condition to treat, and this requires sensory integration therapy and not your regular physiotherapy. Okay? And the overall incidence of idiopathic toe walking is estimated to be around 5%. So once you have ruled out all the pathological conditions, should you label every toddler who toe walks as an idiopathic toe walker? So there are stages of ambulation. A child first starts walking with what is known as tilted leg shuffling. Then he starts cruising around by holding onto furniture. And then finally, the normal gait, that is the heel-toe gait, develops, where there is at the initial contact there is a heel strike, then there is a mid-foot contact, and finally there is a toe off. So this is the natural what happens in the development of ambulation. What is important is that in the first two stages of ambulation, the child may tiptoe. This is normal. This is normal what I am talking about. So that essentially means that toe walking gait is a normal variant in the intermediate stages of motor development of a child. So if in the first two stages a child is toe walking, that cannot be called as an idiopathic toe walker. That is not pathological, that is physiological. Something like physiological bow legs. Physiological bow legs till the age of 3, it is normal. Similarly, this physiological toe walking should disappear by the age of 18 to 24 months. So to label a child as an idiopathic toe walker, the child should be more than 18 to 24 months. What are the causes of idiopathic toe walking? Frankly, the causes are not known, but the causes which are proposed are: number one, genetic, increase in type 1 muscle fibers, sensory integration deficit, which I mentioned, very common in autism spectrum disorder, and early use of infant walkers. That has been proposed to be one of the causes of idiopathic toe walking. Clinical presentation, so mainly the parental concerns are cosmetic concerns and social concerns, and also the parents would complain of frequent tripping and falls. What do you see on clinical examination? Simply you may see tight TA with restricted ankle dorsiflexion. But as I come later, in some cases that may be absent. So you may have a good ankle dorsiflexion even in a child who is walking on the toes. Now, what is the natural history of idiopathic toe walking? And here there are two distinct courses. If the child does not have a restricted ankle dorsiflexion, that is, the child does not have a tight TA, in such cases, spontaneous resolution of toe walking has been noted in 60% cases by the age of 5.5 years and 80% cases by the age of 10 years. No significant functional disturbances or pain or deformities have been noted in these children. So this I am talking about children who do not have a TA contracture, who have an unrestricted ankle dorsiflexion. On the other hand, children who have a restricted ankle dorsiflexion, they frequently complain of pain, falls and psychological consequences, and these children, they warrant early intervention. So now finally coming to what interventions can be offered. So the child is now more than 18 to 24 months. You have determined that he is an idiopathic toe walker. Now what can you do? In the young children with there are no limitations of ankle dorsiflexion, you generally first go for the conservative line of treatment. However, in older children where there is an established TA contracture, where the ankle dorsiflexion is not possible beyond neutral, in such cases, most of the cases, surgical treatment is needed. Conservative treatment does not succeed in stretching out the TA contractures in many of these cases. So what are the conservative treatment that you can offer? Now, so therapy, that is the first line of treatment. So most cases that come with idiopathic toe walking, we refer to the therapists who have different modalities by which to treat them. Then orthosis. So there are some studies which have reported the beneficial effects of AFO in children with idiopathic toe walking. What can we as orthopedic surgeons do in such cases of idiopathic toe walking? On the conservative line, if the therapy and orthosis are not working, then we can do serial stretch casting like what we do in CP. And there are also reports where they have used botulinum toxin with stretch cast. So that is injected into the gastrosoleus. So that has, there are reports regarding this as well. What are the surgical modalities? And surgical modalities are needed in children who have an established TA contracture and who are not responding to conservative line of treatment. For these cases, you need to lengthen the gastrosoleus. Again, how do you lengthen the gastrosoleus? That depends upon the degree of your tightness and upon the results of your silver skull test. So that Dhiren sir has already described in detail as to what are the surgical interventions that you can do in case of TA contracture. If the silver skull test shows that only the gastrocnemius is involved, then you can do a Barker's or Vulpius gastrocnemius recession. However, in cases where there is the silver skull test shows that gastrosoleus both are involved, here you may do a Hocke's or a white slide lengthening. TA lengthening, tenotomy, that is, complete tenotomy is not recommended in this situation. The aim of your surgical intervention should be to achieve at least about 10 degrees of dorsiflexion. Outcomes, frankly, this is not a very well-studied condition, and outcomes of interventions are not very clear. There was one study in 2013 where they attempted to study it was a meta-analysis actually, where they studied the results of serial casting versus Botox with serial casting, and the results of this meta-analysis were inconclusive. They could not come to any conclusion. What is my treatment protocol? So when the child first comes in, I refer to physiotherapy. After an adequate trial of physiotherapy, the child is not responding, I go on to AFOs. Injection botulinum toxin is the next step. This is especially in cases where I can, with sustained pressure, get the the ankle to some amount of dorsiflexion. So if the therapy and AFOs fail, then I would resort to injection botulinum toxin. But surgery is required in established gastrosoleus contractures where the first 2 lines of treatment are failed to give the desired outcome. That's all from my end. Thank you.
Last talk, the talk was given that many things, macrodactyly, osteochondroma, osteochondrosis, and foot in limb deficiency. Foot in limb deficiency is already covered, so I'm not going to repeat the fibular hemimelia and tibialar hemimelia. So I'm going to talk on the macrodactyly. The macrodactyly is nothing but the enlargement of the toe or the ray, enlargement of the phalanx, maybe distal phalanx, middle phalanx, or a proximal phalanx, or maybe the ray, along with not only the enlargement of the rays, there is a length and the width of the ray would be more. That is a macrodactyly. The macrodactyly is one of the frustrating condition for the parents because it cosmetically looks ugly. And it is also the frustrating condition for the orthopedic surgeon because there is no consensus for the treatment for the macrodactyly. So I am going to talk on the broadly how should we approach the case with the macrodactyly, and there is not a single treatment or the single protocol. There are multiple options to treat with that, and whenever it is needed, we can use the optimal treatment for the macrodactyly. So I'm going to talk on that, the issue with the macrodactyly, what are the goals of treatment, options and choice of option with this few case example. As I said that the macrodactyly would be the enlargement of toe. It may be isolated with a single toe or it may be associated with the multiple toes. We can see about the first picture on above, the top would be only the one toe is enlarged, and second picture we can say grossly the enlargement of the second and third toes. But it's not only the enlargement of the toe, the length and the width of the foot is also the very different. So if the width and the length of the toes would be very different, the parents usually complain that the same size shoes would not be fitted for the both sides. So that would not be the only cosmetic problem. This is a grotesque looking the foot, and that is not acceptable in our society also. There is a very commonly associated with all the syndrome, but whatever syndrome is there, whether it will be associated with the neurofibromatosis or hemangioma or lymphangioma or the congenital lipofibromatosis, we need to find out whether it is only the foot issue, whether the foot and ankle issue, or it may be associated with the entire lower limb is involved. Like the Trenery-Weber syndrome, or that would be the syndrome that will be affecting the entire half of the body. So we need to always examine, so we have the opportunity to examine the child from top to bottom and see it's a part of syndrome or only the macrodactyly of the foot. We need to find out that. What is the aim? To aim to find out what is the functional issue, relieve the functional issue, get about, sometimes it would be associated with pain, particularly patient with the hemangioma or lipofibrosis or the neurofibromatosis, but where the fitting of the shoes, where they have the pain, so you need to relieve that. And the third and the foremost is the cosmetic. Cosmetic is that it's grotesquely looking the foot, it doesn't look the good appearance. To get about the similar size, we may not achieve it, but it's try to get it as much as possible to opposite side. So what are the options? The option is that the soft tissue debulking. Very commonly it will be combined with the osteotomy or the epiphysiodesis. Isolated the soft tissue debulking doesn't work. It will require to have amputation of the toes or the ray amputation. Soft tissue debulking is commonly done with the procedure, but we need to do about a repeat of the soft tissue debulking associated with the epiphysiodesis or the ray amputation or ray resection. Soft tissue is necessary to repeat that, and whenever the great toe is involved, the result is often only the fair, and it will be required to have a repeated soft tissue debulking procedure. We remove the soft tissue which is enlarged. The second issue is there epiphysiodesis. We need to do about the epiphysiodesis of either the metatarsal or a phalanx or a both. Why need to do about that? The first 2 years of the child's growth is faster than anything else. The physis of the child would be working very fast. In fact, the child attained the half of the foot of the adult size at 2 years. So that is very important. So if you want to do the epiphysiodesis, you need to do it quite early. And if it is a child reaches to the permanent, compared to the opposite side, at the adult size, you need to do the complete ablation of epiphysis, because that is very necessary timing. Most of the time we may be too late for doing about epiphysiodesis, but it can be combined with the debulking. The third would be the commonly done is the ray amputation. If it is a massive enlargement of the single ray, then it is very important to do about ray amputation. That would be single surgery, and it is quite effective. Second time, it is very commonly used for the recurrence, because it's invariably the pathology are not dealing, so it will lead to the recurrence of this. So I'll go to the few example. That's if you see about the left side, the second toe is the bigger. If you see about the width is quite more. This is the 8-year-old child's been treated. If this is the X-ray, the space between the first rib space is even wider compared to the opposite side, and because of that, the first ray is going in the adduction. There is a metatarsal adductors on that. So the child has been treated with the osteotomy. It's called as the ray reduction, the osteotomy. It's the metatarsal shortening osteotomy along with the phalanx shortening osteotomy, and it is united quite well. And if you see that, it looks reasonably okay, but is not looking normal. So the child will require in subsequent follow-up the debulking. But what is not a good idea to take out the amputation of the great toes, because the great toe is it's very important. So the ray amputation is not a good option to do for the great toe. But second toe, if it is isolated second toe, we can do about the ray amputation. Second example, it will be the enlargement of the great toe. Along with that, so much that is the incrowing of the toenails are there, and the soft tissue is so much. So it's we need to do about this are the X-rays, where there is a dorsiflexion deformity of the IP joints. So what is needed about that? In case of that, the ray reduction, the osteotomy of the phalanx, that we reduce the width and fix it with the wire and do about the soft tissue bulking. And if you can see about that, it's not only the proximal phalanx, is that distal phalanx also done about the vertical osteotomy and reduce about width of the size. So its length is also reduced and width is also reduced. It's a 6 months follow-up and it's a 2 years follow-up, and child has got reasonably well, and ingrowing toenail has been corrected. We can see in X-ray soft tissue. I don't have the photograph, but in a soft tissue we can see it's symptomatically is quite free, and the child is doing quite okay in a follow-up. The third case where we can see there is a grotous deformity of the second and third toes, where there is a reasonably looking, the first great toe is okay, but the second and third is really the wide, where it's looking it's grotesquely wrong. So what is done, that we have taken out about the ray, and along with the phalanx we have taken and the metatarsal also. So it looks like the ray amputation, but we kept the width in compared to the opposite side. So this is the pair of pictures. And if you see in a follow-up, the size of the left and right foot, we taken the footprint, it looks almost identical. Though there are the rays is absent, but the cosmetically looking, the tripod has been maintained. The first ray, fifth ray, and the calcium has been maintained. And this is the clinical photograph of the child. It looks reasonably okay, and functionally also it looking okay, rather than having grotesque foot. The fourth case, that is an infant presented with very grotesque. We can see about the width is more, the size is more, the depth is more, all the 3 dimension it is more. And these are the challenging case where we cannot do about the ray reduction, we can't do about ray amputation, we cannot do about the soft tissue, because it's going to come repeatedly again and again. And the child has got you can see about the thigh, there is a hypertrophy of the thigh and the leg also. So we need to deal with that. I'm not going in detail about the epiphysiodesis time of the femur and tibia, but for the foot, it's a grotesque looking the foot, where we need to do about the multiple surgery, and the child was first treated with the ray amputation at the one side, and if you can see in the follow-up, child was looking reasonably okay, but where this is it's a 4 rays, you can see it's a 5th ray, it's 1 ray has been absent, but this is also we have to do in a ray reduction osteotomy. And later we did also the second times also, we removed the second toe, and it was looking quite okay compared to the opposite side, but still the story would not be over, because child is reached to the 8 years, from the infancy to 8 years. Last case, not but least, is that if you see about that, the patient has got the polydactyly, and along with the polydactyly there is a metatarsal, the head would be long. If you see that, the child has got a duplication, and is a shoe fitting was a problematic. So it's required to do about the excision of the extra rays, along with that about metatarsal osteotomy aligned put with the metatarsal. We have not to fuse about the metatarsal phalangeal joint, but you can stabilize to prevent about the valgus or varus. So in short, the microdactyly is that's one of the frustrating problem. Always examine the entire body, hip, knee, ankle and spine, to rule out about associated syndromic association. Soft tissue alone may not work in the case. The epiphysiodesis, osteotomy, ray reduction or ray amputation are the good option, can be combined with the epiphysiodesis, can be combined with the soft tissue debulking, but repeated procedure is required in case of the macrodactyly. Thank you.
No. There is no, neurocutaneous markers or any available. Is there any role for, MRI screening to look for any, inside whether there is any, AV malformation or any, neurofibromatosis which is leading to, this problem? I'm talking not just of macrodactyly, even it can be, hemihypertrophy or things like that.
Yeah, actually the answer is no, but for my pleasant surprise, I can give you my example. We had one child with the CPT, pseudoarthrosis, congenital pseudoarthrosis tibia, and it's been operated in 2014. It's quite reasonable. It's united very well. He's under follow-up. Now his child is 8.5 years. The rush rod has become short. He was lost after the COVID. He came back, and the opposite side is having neurofibroma. Okay, the opposite side, not about the bone involved, but soft tissue neurofibroma, and that would become painful. So what was suggested, because MRI was not working, I asked that get the MRI of that particular part, because it was painful, because we have to revise, we can excise that part. So the father is the teacher, and he's one of the relative is doctor, which he suggested not only the MRI of the leg or the tibia, he said entire spine MRI and MRI of the brain. For my pleasant surprise, the child has got gliosis, the brain intracranial, as well as the dumbbell-shaped tumor in the spine, and that is totally asymptomatic. So those cases, even though it has been detected, we are not going to treat for the. So this is an example I said, because he came with the 4 MRI and said, sir, these are the MRIs, just have that. So I said, I'm not going to treat the MRI because it's good. It's for the academic purpose, it looks good, but you are not going to intervene unless it is going to change the natural history.
Any other question?
Sir, there was a child I operated, at the age of almost 2, but he had an equinus contracture of almost 30 degrees. On initial examination, such a severe contracture, I thought that definitely there must be some underlying neurological abnormality or anything. We got a neuro evaluation, a thorough evaluation done. Nothing turned up. So he was actually a case of isolated gastrosoleus contracture. Difficulty in walking, having frequent falls. So in that case, we operated it too. But other case, in milder cases where the contracture is not very severe, maybe about 10-20 degrees of contracture is there, 10 degrees of contracture is there. Child is able to walk. Okay, I may give a very sufficient long trial of conservative treatment, physiotherapy, maybe AFOs also in some cases. And there is no hard and fast answer to that, I think literature doesn't talk about, in fact,
The natural history of this disease. So there is no point of hurrying too much early to suggest surgeries. So I just say that this is one option when you are willing to undergo that procedure. Come. Because in our cases we used to delay as much as possible. That's absolutely perfect. And here you
can take out also the skin with the soft tissue and say that till it is a tension-free closure we can do. We cannot take out everything, but whenever we take about the skin, we go in so much depth, so we will not disturb the flap on either side. So that would be the key to reduce about the skin necrosis. Otherwise, if you will be very excessively taking about the skin and a soft tissue debulking, there would be, if you do about dissection on either side, it will lead to the invariably skin necrosis.
I would like to draw the opinion of the House of some of the cases, very common cases in our opinion.
Sir, Chairperson, sir, my seniors, I am going to discuss about 2 cases pertaining to ankle deformity. It's not coming on the screen. Yeah. You can see the video. 17-year male presented to us in OPD with deformity of his right ankle and pain on excessive walking. You can notice the deformity. Anybody from our residents? Is it visible or not? Heel valgus and shortening. This is the clinical photograph. Heel is in valgus and medial side of the distal part of leg is more prominent, and there is, on examination, there was 2 centimeter of shortening also. This is his X-ray.
Sir, can you go back?
Yeah, so because if you look at clinically, the valgus does not appear to be at the foot, it appears to be above the ankle.
Yeah, lower part of the distal leg, just above the ankle. And
one point which Dr. John asked me in my lecture, that there is a deformity at the proximal to ankle, but there is a reverse deformity
Yes, sir.
below
Subtalar
that.
compensation
So
also.
now, before doing the surgery, we just have to ensure that that much part is the corrected. Otherwise, what will happen? The child will have a varus deformity distally, because now foot is not going to compensate. So it's very important that
Yes,
we examine the foot.
Yes, sir. That is the point. We noticed also that even there was a deformity just above the ankle, the patient was keeping his full sole on the, because he was compensating at the subtalar joint by creating a varus. And here we can see in the photograph also. This is his X-ray. Distal part of tibia is deformed. Anybody from the residents, can you point out something in fibula? Maybe healed fracture. This is his scanogram.
It's the result of some growth disturbance, maybe. Some sort of, either post-traumatic or
growth, yes.
post-infective.
Yes, sir. Might be
What is the
growth
past
disturbance.
history?
We'll go to that. So, one possibility was trauma, second was infection, growth disturbance like facial defect or facial arrest, maybe dysplastic causes or iatrogenic. Some intervention may have been done in the childhood. So, this is his previous X-ray his father collected and came in next OPD, that the child was having fibular osteomyelitis in the childhood. At that time, he was operated, and gradually you can see that his ankle was absolutely normal at that time. Follow-up X-rays. But here we can notice that the distal tibial physis, there is a wedging, angular deformity, and now the deformity has just started. No, it is still subclinical. Gradually, the patient started developing deformity in 15 and reported to us. And this was his clinical photographs immediately before surgery. You can see that there was shortening, and there is a anteromedial bowing of the tibia with the valgus deformity and subtalar compensation. And distal part of tibial physis is almost 90 degree to the long axis of the tibia. So in this case, we were a bit confused what to do. This is the problem statement. What are the problems the patient is having? There is compensatory varus at subtalar joint also. So one option was not to intervene. Don't do anything. Anybody will go with this? We should intervene. Since there was a fibular defect, so one option was to fix the fibula and correct the deformity. And the deformity correction, the distal part of the tibia by osteotomy and fixation with K-wire. But there was an issue of shortening also. Second option was putting a Lazaro. And third is LRS fixation and lengthening. So we did simple surgery, and since there was a deformity was very severe and there was subtalar compensation also, so instead of correcting it completely, we went for partial correction of the deformity. As sir was showing the osteotomy of the distal part of the tibia, we did the same thing. First wire went perpendicular to the long axis of the tibia, and second was not parallel to the joint, it was less than that, fixed with K wires. 5-month follow-up. The patient was standing, but here now we will notice that the forefoot deformity has become prominent. He is compensating to put his foot on the ground. On 9 months follow-up, the shortening is apparent now. The heel is up. 16-month follow-up, good union, alignment is better, not anatomical. And this is 5-year follow-up. The patient is attending his college classes. Now he is comfortable with walking with shortening. 2 centimeter of shortening is there. Valgus deformity has improved. And the parents are now planning to go for lengthening, because there is around 2 centimeter of shortening. They want that at least it should be corrected now after 5 years.
Can you go back to the previous X-ray? So the talus looks very grossly tilted. Okay, so are you worried about that? Because
Distal part of tibia, if you see, it is not exactly perpendicular to the long axis of tibia. It is in extension. Sorry, it is in flexion.
no, it's severe
Valgus
valgus.
and
So
flexion
it's
both.
almost rotated 30-40 degrees that way. So I think this is something that may cause problems later.
Yeah. So in long-term follow-up, we have to see what's happening in the subtalar joint also, and also the tibial talar joint.
I think there is some compensatory reverse deformity in the subtalar joint. That's why, clinically, he's still looking straight. Yeah, that's going to be that. He'll develop ankle arthritis.
Sir.
So,
Specifically mentioned that you have not corrected the deformity fully. Why it was like done purposefully?
Yes, sir. Purposefully, because we were not operating the subtalar joint. Because
Okay,
there
so
was a
you are worried that it
compensation.
may not compensate fully.
Yeah, we were not correcting the compensatory subtalar as well as the forefoot deformity. Therefore, we went just partial correction.
How do you rate the other modes of fixation like Ilizarov or Jess or gradual
Ilizarov is
correction
a
and gradual lengthening?
compared to all other fixation at 17 years of age, Ilizarov is a better option, because we can do a 3-dimensional correction, plus we can do the lengthening also.
And
But
gradual
because of
correction
subtalar joint and other foot joints nearby, we didn't went for that, because in those cases we cannot correct one joint at a time.
And
We
gradual
have to
correction
correct all the other.
will also take care of the compensation taking place at the subtalar joint gradually.
Yeah, in that condition we'll have to extend that Ilizarov frame down also up to the calcaneum.
yeah, so such a severe deformity, I think, gradual correction would give more. Now, additionally, this is a 3-dimensional deformity. Okay, you want to lengthen as well. So, in such a complex deformity, even with the Ilizarov, arranging those hinges can be very difficult. So, the modern way of doing this is, doing with the hexapod. And now we have an Indian-made hexapod, that is the DEFIX system, developed by Dr. Mangal Parihar from Mumbai. Very convenient to use system, very simple. Software is also very, user-friendly. So, that is something which can be applied in this particular situation. And additionally, obviously, you would, if you correct the ankle deformity completely, you would need to correct the subtalar joint as well. Yeah.
Very good. Dr.
Thank you,
Ritesh,
sir.
please
Next
proceed
case.
for your next case.
This next case is about a 11-year male who had a surgery elsewhere for a talar fracture, and after that surgery he had an infection. You can see that the X-ray fixation was done, there was non-union and avian changes. The patient presented to us in March 17 after removal of screws. He had a persistent discharging sinus on the medial aspect, and he was having a stiff ankle and not responding to antibiotics by this where he was operated earlier. So this was his finding in the OPD. Pus was coming out through the scar, and there was no movement at the ankle joint. Lab reports, ESR was raised, CRP was raised, and his pus culture report was MRSA. This is his X-ray in March 17. You can see that the talus is sclerosed at the fracture site, non-union, Lower part of talus, subtalar joint appears in anatomical position with some changes, and on AP view we can see some lytic areas in the talus. Any, Dr. Sandeep, anything you want to point out?
Is this neuropathic? Any?
No.
What is
he
the
has a-
history? Trauma.
He has a trauma. You can see that.
It was a compound screw was put.
Yeah. He was treated elsewhere. He presented to us with a pus coming out through the scar tissue.
And the pus is still persisting.
Yeah, the moment he presented to us, screws were removed and pus was coming out through the scar tissue, and the
So
patient was having a stiff ankle.
So the priority now first is clearing the infection.
Yes.
So I think I would get an MRI done over here, see the exact extent of where the infection is, where are the sick crisps, and then plan for even the calcaneum is involved, I think, there are lytic lesions in the calcaneum as well.
Yeah.
And the talus body is also avascular.
Yes, sir. That body is, proximal part has become avascular. So one option is to go for MRI. Anything else we can do for investigation in this case? We did only pus culture, X-ray, and we didn't went for MRI in this case, as the just to find
So
out.
again, pus culture honestly does not tell you anything in these chronic discharging sinuses. Okay, we do it sometimes, yes, but eventually it's culture which you get from inside during your surgery. That's really going to be so ideally you should stop them on antibiotics at least 2 weeks before surgery, before you go on to surgery.
Yeah, the moment the patient was operated where he was given a lot of antibiotics. But the moment patient came to our OPD, we stopped antibiotics. No antibiotics, then pus culture was done, and we didn't went for MRI as patient was not willing for that. So in X-ray there was a deformed flat top talus, gap with a sclerosis, and subtalar joint was intact. Distal tibia was appearing intact. So investigations and treatment options were there. So one treatment option was first to take care of infection, and for that debridement is the option. And after debridement, once defect is there, what should be we put inside? Either cement with antibiotics or bone substitutes. And then how to fix that fracture area?
So I think you need to, ideally assess that fragment, because if that is avascular, then the chances of any infection healing with that avascular fragment becomes poor. Okay, so that's one thing that you have to make a decision on.
So one thing was to find out the vascularity of talus. That is very important.
Let's see what you did.
Is it essential to get it before debridement?
Ideally, yes. But if you say it refused an MRI, then it's different.
Because in that case, our treatment plan may change. Only with that.
The treatment plan would be just drilling the avascular area. That is probably we will add on to the surgical procedure.
It may not, because you probably, then you have to release the tunicate when you do that. Just take out the whole fragment.
But the moment we'll take out that talus in the child, 11-year-old child.
11 years, the foot growth is more or less done, 12. But the foot doesn't grow beyond 12 or 13 anyway.
Because in that case, arthrodesis is one of the options.
Then if it is a painless ankylosis, then just leave it on.
Yes. So infection control is the priority, and for that we were just thinking about what incision we should use, because initial surgery was done through the medial incision. So one option was anteromedial incision or anterolateral incision. So anterolateral incision we opted for because it gives a good view of talus, and we can see whole of the talus as well as talonavicular joint also, and we are away from that infected scar. So we went for that, debrided, curated, and then we put antibiotic mixed cement. This was removed at 6 to 8 weeks, and after that bone grafting was done, because at the time we saw that talar surface was fine, Articular surface was posteriorly it was intact, anteriorly it was rough. So we simply put a bone graft in that area. This is 5 months follow-up. The scar was well healed, no pus discharge, ankle was still stiff. 9 months follow-up, the patient was able to squat with limitation of dorsiflexion, but it was painless. And you can see that on X-ray, talus has healed with a sclerosis, AVN changes, and there is a talotibial joint surface has started appearing now. This is his 9-month follow-up. He is able to walk with a limp. Able to walk with a limp. This 20 months follow-up. It is getting better. Now around 5 to 10 degree of dorsiflexion is possible. Here you can see 4 years follow-up. The child is, now foot is appearing fine and he is able to squat with changes in the talus, but it is painless. And this is 6 years follow-up. He is able to walk without any limp with a wasting of right calf. You can notice in his photograph that the right calf is wasted. But he is able to do all his activities now.
So I think the result looks great, but what did the graft actually do? You haven't got the fracture to heal.
Now we have just inserted the graft in that gap in the talus because it was not sequestrated, it was intact and it has healed with a sclerosis.
Show me the last X-ray. Okay, so that's, the talus is healed in that deformed position. So what is better, excising it and leaving it as a pseudarthrosis, or getting a situation where you know he's going to get arthritis later?
So if we create a gap in a developing child,
12, by the time he's 12, I don't think it makes so much difference here. But, I mean, it's a debate. Because he's going to end up with arthritis in that ankle fairly soon.
that we have to see because it is a very short follow-up, only 6 years. So after 10, 15 years, we will come to know that at present he is
Osteophytes, etc., forming in the beaking of the talus, which is suggestive of him developing OA.
So after treating the infection, first priority is infection treatment. So care of infection precedes other interventions, and long-term follow-up is essential in these cases for functional outcome.
Very
Thank
good
you.
and nicely presented both cases. Thank you, Dr. Vitesh. Now we
We'll felicitate our chairpersons now.
Okay, go ahead.
Dr. V.K. Sinha, sir. Sir, John, sir. Please do the honor, sir. Dr. Rajacharan, sir. Dr. Praveen Sahu, sir. And Dr. Chandan Soni, sir. So there are some announcements from John, sir, and then I'll proceed to vote of thanks.
A couple of announcements. One is about the next POSICON, which is in Guwahati, from February 16th to 19th. I think we should have a big delegation from Bihar going there. It's going to be an excellent program. We've got a lot of international faculty coming there, and Dr. Sukalyan is going to be the organizing secretary, so he's here. And I think this is a meeting which, for all of you who are interested in pediatric orthopedics, is going to be a must-attend kind of meeting. That is one. There's also a EPOS POSI webinar tonight at 8:30, which is to do with complications in pediatric orthopedics. So I think this hasn't been circulated to everybody, no? Okay, so we'll share that in the group. So those of you who are interested in attending the webinar tonight are most welcome to do that. Just thank you all. I was surprised at the kind of response that we've had to this meeting. I really have to thank all the faculty, Dhiren, Hitesh, Sandeep, Sukalyan, and all the local faculty also, who I think did an excellent job, and to keep everyone interested. And it's surprising that we still have so many people here on the second day, and that is very encouraging. And it just shows that the interest to learn is something which you can't sort of suppress. Okay. So thank you very much, and I'll leave it to Dr. Jaswinder to give his final vote of thanks.
So before coming to the end of this CME program, I would like to thanks everyone, whoever is present here, all the delegates, the faculties. This was a 2-day program and we had a lot of brainstorming sessions. Thank you everyone. We had it in association with POSI, ORF India, and of course our own Paras. So thanks the marketing team, Vinod, in and out. Since last 4 months we have been working. We had 7 sessions and the last workshop is still pending, and I think there were a lot of brainstorming sessions. Thanks special to the delegates who, as sir just said, you are the crux of this conference, and without you our conference would not have been a success, the CME. I'm sure you would have learnt a lot and everyone here would have become much wiser by the end of the day. I thank our sponsors, Depusynthesis, Cure India, Pitker, and SAT. There are a lot of workshop materials and things given by them. And it's time to felicitate our faculty now, especially the national and the local faculties. So may I invite again John sir to do the honors, please, sir. So Dr. Dhiren sir, please. A big round of applause for him. He is like so many videos. He makes all of them himself. How he makes also, he has shown in one of the COVID sessions during that time how he makes a video. So it is wonderful the way he presents and expresses his thoughts into the videos. And thank you so much.
Just add to that, like Sukalyan wants to learn about that. So he's probably like fix up a date and then we can spread the information in the group. So whoever wants to join in Zen Zoom meeting. Perfect, yeah, that would be good. Sure.
Janki, we'll have it. Yeah. Next, our national speaker, our faculty, Dr. Hitesh, sir. Thank you so much, sir. This is the 3rd time we are inviting him subsequent. And he's like our pillar. This POSICON only we decided how to do, what to do, and he decided for all the faculties. And I'm sure for all the upcoming events, he'll be always there with us. Dr. Sandeep Vaidya sir has come from Mumbai. Thank you so much, sir. A big round of applause, please. With the marvelous, his knowledge, expressions, the way he presents. Thank you. Dr. Sukalyan, who's our organizing secretary for the POSICON 2024, which is going to be held in Guwahati. Dr. Sitanshu has already left and we have felicitated him yesterday itself. Dr. Ritesh Runu, sir. Dhiren, sir. Aye na. Sir, please. Felicitation. Dr. Ritesh Runu, sir, from IGMS. Thank you so much, sir. All our local faculties have always stood with us. Next, Dr. Ritesh Pandey from AIMS, my colleague. Thank you so much. Thanks for being a pillar of the Paediatric Association from Bihar. Dr. Saurabh. Thanks, Dr. Saurabh, and he has been always there with us. And Dr. Shashikant was not well, so he could not attend the conference. We'll pass over the memento. And finally, our own Dr. John Mukhopadhyay, sir. So, requesting all the faculties, please, all the faculties from local and national, please. And finally, sir, हो जाएगा sir. And I'm sorry if I miss everyone. We, as a Paras team, everyone from here, we are sorry if we have missed anyone. And finally, this was our second pediatric event. The last was on pediatric trauma. It was in Lemon Tree last year, and Dr. Hitesha sir was there. Again, we will be planning for the next year. We'll be announcing soon what all are our plans. This is a time for a feedback. I request if any of the faculties, they want to give a feedback so that we can improve from here on for the next, please. If anyone wants to say anything, and followed by the delegates also, please. Any feedbacks, please?
Superb and well managed, and what we all wanted was pure academics. So we don't want much facilities as in other conference. Thank you.
Thank you. And please, you can say everything is available, all the recordings on Ortho TV, as already said. Any more feedbacks, anyone? We already had a faculty picture, and finally, this is the last slide. We'll proceed to workshop. And so we have two tables at the end, and we have bone models and a rubber model. Dr. Dhiren sir and we'll ourselves will divide the faculties, and whoever are interested, please will go to the. So he says that he'll send it, sir. Thank you.
Basically, like yesterday I asked the question that how many of you are doing Ponseti, and almost everyone are doing it. So this workshop is probably going to become very routine for you. So first of all, we are giving or some time for the discussion. So please let us know what questions you have about that, and then we will go for the hands-on part. So what difficulties you are facing? No one has any difficulty. No, then there's like you are afraid of asking the questions.
Sir,
Dr. John, your impression is
foot is a bit small rather than to be the normal one.
That's a very, very good practical question, and a lot of time parents, they go on asking the question, which is a problem in clubfoot, not the overall length. So the lower limb length is not a problem, it's the foot length which is a problem, and for initial 2-3 years, they go on complaining this. Now, we need to remember that when it's a bilateral deformity, we are not worried about this, because anyway, both the feet are going to be small. But in a unilateral feet, the two complaints which they always make is, the first is the length of the foot is less, and the second calf circumference, which is less. So we need to explain this at some point to that these are going to be there for lifetime. But usually my experience, like initially for 1 year or 2 years, 3 years, they complain about that. And later on, I have not seen any child coming back with that complaint. So
I think it's important to counsel them before you start the treatment, that these two things will remain. One is calf circumference. It is always thinner than the opposite side if it's a unilateral clubfoot. They'll have strength, they'll have power, they'll have everything, but it will always be thinner. So I think it's important to counsel them right in the beginning. And the foot size, not always, but very often the size difference can be more than a couple of sizes in terms of the shoe wear. Okay, so you need to counsel them on these two things right in the beginning. Tell them that there's nothing that we can do about it or intend to do about it, and that is part of the disease. Okay, because that's where the problem is. It's actually the calf muscles which are partly hypertrophic, which is responsible for the deformity. So I think this is definitely a problem. In spite of that, there will be people who will complain about it, or so maybe you should get it written down as part of your initial counseling.
yeah. So what we will do is like in the first few minutes, we will go through the presentation to again repeat. Probably everything has been told by Dr. John in the yesterday's session, but still this would be a good repetition, and probably new animations may give you some idea. Then if you are keen, I can play the video of Dr. Ponseti himself giving a plaster. That is one option. It's a 23-minute long video. So if you want to see that, we can do that. We can play that video. If you want, then Jaswinder will share that video with you by email, so you can keep that video whenever you want to apply plaster. So it's up to you. But first of all, let's see this. That may probably ask you a few more questions. My WhatsApp number is here, so if you want any of the animations, any presentation, please let me know. I will share that with you. So what is the sequence of correction? Already we know that the sequence of correction is cave. So it's a cavus, adduction, varus, equinus. This is what they are teaching us. I would just like to add one point to that, that please don't go with the idea that first plaster is for cavus correction, second, third, fourth plaster are for adduction and varus, and the last is for equinus. We correct almost everything simultaneously, so that's one thing which I would like to clarify. For cavus correction, yesterday we saw that what is cavus, so I will going to repeat the same thing like what we do it in cavus correction. So this is a hind foot for a right side. The oblique plane, yellow plane is suggesting that hind foot is in varus. Now in relation with the hind foot, the forefoot is pronated, right? So the first metatarsal is plantar flex, then the fifth. And if you look at the plane of a forefoot, which is in a blue, please don't take a picture, I am going to share with you. So don't worry about that, just focus on the lecture. Now if you see the plane are not parallel, they are in a different thing. Now the question is like if we want to correct cavus, what should be the maneuver? How we should correct it? We need to lift the first metatarsal, that is how we correct it. So we lift it or we supine it. That is what we need to do. And when we do it like this, it gets aligned with the hind foot. Now, just one point which I would like to clarify. When we do this, sometimes parents complain that you have already increased the deformity. So this is one thing which we need to explain, that this is we have done it purposefully. Because they see that now even the forefoot initially was like this, but you have over-corrected, or like you have increased the deformity. So that's first thing. For that, how do we keep the fingers on the model or on the plaster? So we have two ways, but if we do it with one finger, then we have to keep it on a medial and plantar aspect. So as shown over here, we keep our index finger on a medial side and on a plantar side. And then the thumb is on a lateral aspect of head of talus. Yesterday we already discussed how to palpate head of talus. Can you repeat how we palpate that? Perfect. So that is how, like say, lateral malleolus is always palpable. We go 1.5 centimeter distally, means anteriorly, and slightly plantarverse, and that is where the lateral aspect of fibula is. So the thumb is there, it's giving a counter pressure. So this is the picture how on the child, how we keep the fingers and the thumb. The point which is like nowhere in the club foot we invert the foot. The foot is in inversion, and please don't try to twist it in a other direction. So this is a picture which one of my colleagues sent it, and I am showing over here just to emphasize that we are not everting the foot. So in Ponseti, we are not everting the foot at all. All the time we are abducting and keeping it in the same plane. So this is the message, that please don't do that. And these are the pictures from one of the book, like where we are trying to show that eversion is not the maneuver which we do it. Coming to the second step, in which we are correcting both abduction and varus simultaneously. So here the thumb pressure is on the lateral aspect of head of the talus, like the previous correction. But the important thing which we would like to understand, and I say that the Ponseti's major contribution is this biomechanics which he explained. So I will try to explain that concept. So what we do it, this is a foot model. We apply the first thumb on the lateral aspect of head of the talus, and then by the other fingers, other hand, we try to apply the pressure from the medial side of the foot. Now instead of plantar side, we are purely on a medial side because we want to correct adduction. This is the interesting thing. The talus is in red. Oval is a calcaneum which is lying underneath that. So we are looking at the foot from top. Try to look foot as a two-level model. On the top floor, there is a talus. And on the bottom floor, there is a calcaneum, there is cuboid, fifth metatarsal. On medial side, there is navicular, medial cuneiform, and the first metatarsal. Right now, how correction takes place? Look at this. We have applied the counter pressure on the lateral aspect of head of talus, and we are applying the correcting force from the medial side of the forefoot, and this is how it gets corrected. So just we are abducting the foot and rest of the thing are getting corrected. So why and how this happens, let's see that. Before that, let's see this again. The navicular pushes the cuboid laterally. The cuboid will push the anterior end of calcaneum and will take it laterally, and that is how the calcaneum will rotate. This is what the correction takes place. So this is, I think, the major contribution of Dr. Ponseti. It's not the plaster technique, but this concept which he explained, that if you do like this, then the correction will take place. And sorry, the video is not playing, but can you give, yeah, you have already shown it. I will show it again on the model. No, probably the video is not right, but don't worry, I will show. In the Ponseti video, Ponseti himself is showing this thing. So, like you are looking at the foot. So, I am holding like this, the hind foot is in varus. Now look at, we are correcting it. Can you give me your model because the elasticity is. Take pictures of model, yeah, please. Yeah, so this is the, sorry, like this. Now you look at the calcaneum. When we are applying the pressure on lateral aspect of head of the talus, and when we correct, can you see the calcaneum getting corrected? So we are not holding the calcaneum, and we are not twisting, we are not correcting it. It gets corrected by indirectly with the forefoot correction. That's the most important message.
And even through this maneuver, you make sure that the first metatarsal head is elevated and not pronate the foot when you're doing this as well.
Yeah. So this is what the picture before the forefoot correction. We can see that calcaneum is in varus or hindfoot is in varus, and this is after the forefoot goes into abduction, the heel gets converted. Now look at one thing, it's not only the varus and valgus. Even if you look at the posterior end of calcaneum has gone distally, so there is a correction of equinus also. Look at that, compare this picture. On the right, you can see that the calcaneum has gone down, the posterior end of calcaneum has gone down. So equinus is also corrected. How to carry out step 2? This is a foot model where the skin is removed. This is talus. These are the calcaneum, cuboid, and the other tarsal bones. We apply the pressure on the lateral aspect of head of talus, and this is how we abduct the forefoot. Already we discussed this. This is yellow, is even in chubby child we are able to palpate. Go 1.5 centimeter distally and anteriorly, and we will be able to palpate lateral aspect of head of talus. And then we abduct the forefoot. How frequently we change the cast? 5 to 10 days. If patient is coming from distant place, we can increase the days, or if they are going to stay in the town, then we can shorten the duration. There is no difference in the result. Always ensure that child is sedated. Now, I would just like to have a quick view. Jaswinder, how do you sedate the child?
I ask the mother to feed at that point of time because that is the most relaxed position.
Okay, good. Yeah, Hitesh, what do you do to sedate the child? Don't sedate the child. Just, Sukalyan.
Feed, place the baby on the mother's lap and give him specifiers or anything that calms down the child. Usually the parents know better about it, but no medicines.
So feeding, especially if they're being bottle fed, is a very convenient way to keep them fasting for some time and feed them just as you're doing the cast. But not all children are bottle fed. One is the mother feeding the child. Some mothers will do it quite happily. Others are a little embarrassed to do it. I avoid any definite sedation unless the child is really cranky. Okay, so I have done it once or twice, but I try and avoid that if possible.
Yeah, Hitesh.
So usually the bottle feed or sucklers, they take care of these cranky children, and maybe oral pedicure, as Jaswinder suggested, in few cases.
Okay, good. Allergen, right. Okay, so what I would suggest is slightly different. It's a midazolam, the full set injection which we use. There is a spray available. So we can use that spray. Depending on the weight of a child, we can spray this in the nose, and in 10 minutes it will produce sedation. This sedation lasts for only 15-20 minutes by the time we can complete the plaster. Single spray for like a child less than 3 kilogram. A bigger child needs two puff. Fine, if you don't have this thing, what I would suggest is a simple alternative. We have a full set injection, midazolam injection. Use that injection which we use it for IV. The only thing is like measure the weight of a child and half of that ml. So suppose the weight of a child is 4 kilogram, then we give 2 ml of that IV midazolam injection orally, not injection, orally. The effect will start after 20 minutes and it will last for half an hour to 45 minutes. So that's another way of making the child relax. Before that, always feed the child, because when the tummy is full, this will work really well. Equinus correction, already we discussed that yesterday at length. The point is like the end point. The end point is like we need to correct it up to that level. So we have a 70-degree foot going into abduction, and we have a 20-degree dorsiflexion. A lot of orthopedic surgeons, they ask that why we really want to overcorrect it. I just tell them this is not overcorrection, this is a full correction, because a normal child at this age will have this much amount of mobility. So we are just reaching up to that range. We are not overcorrecting it. Fine. So if you have any question, please ask. We have probably one of the best experienced faculty for the clubfoot.
So Dhiren, about this use of MedSed, this thing, the
Midazolam.
Midazolam as oral this thing, is there some guideline or literature on this? Because
Yes, there is a literature available about that. So the dose which is required in IV is 1/3 of the oral dose, because the absorption is poor. Yes, there is a literature available.
that is you can back up.
Yeah. If in case of problem occurs. And again, the safety limit of this medicine is very high, so don't worry about anything. And it is much more safer and shorter in action than pedicloral. So the effect of this wears off. By the time they leave the hospital, the effect will start disappearing.
So do you do this for every child?
Every child. Every child.
And it doesn't make the child laugh. The plaster doesn't make the child laugh.
Yes, that's again a very good question. Yes, when we are applying the foot or when we are correcting the foot, yes, child will cry for 2 or 3 minutes. But as soon as that part is over and the temperature of the cast comes down to a normal, then again child will start sleeping. But during correction of the foot part and when we are applying the plaster, probably a temperature or a stretching sensation will wake up a child even with this. So it's not that powerful that child will remain sleepy. Yeah.
So we start this treatment nowadays at 1 week or 5 days or 7 days. Do you still give it to them?
Yes, yes, yes.
Yeah, because I at that stage, usually these children are not a problem to cast. So I would personally avoid it unless I have to do it, that's all.
Yeah, so if child is like, say, my criteria of starting the treatment is 2.5 kilogram, that is first criteria, and second is 15 days is over. I don't now start. In the past, I used to do it at 2 days, 3 days, but now I say that we start at around 15 days. So I have used, with these two criteria, I have used in all patient.
Start by about 5 or 7. I mean, if they come, they don't often come at that time, but if they come within the first few days, I usually just say, let the child thrive, be happy that he's feeding properly, etc. And by the end of the first week, I would start the casting.
See, it all depends on your comfort zone. If you are not comfortable with this option, please don't try it. I have used it, so I have become more comfortable using it.
Sir, one problem which I think most of the beginners face while putting the plaster is, like, they are able to locate the tailor head without
Cast,
before
without
putting
the soft
bandage.
roll.
But once they put it, it's very difficult and they struggle to locate that tailor head again. So is there any tip and trick for them to, means how to?
Not, frankly, like, would you like to add to this? Because I don't have anything, but fine, like, see, once you know that the lateral aspect of head of talus is there, and really we don't keep our thumb all the time, we just go on rotating in that area. So, fine, in most of the cases you will be correct. John, would you like to add on to this?
Once you locate it, you can actually feel that sort of movement in the forefoot as opposed to the talus. So when you're doing it, if you're getting that same movement, the talus is your fulcrum, so that's not moving, the rest of the foot is moving. So if that is happening, you're probably okay. And of course, the lateral malleolus, you can, so don't use thick soft roll, okay? So use thin cotton or soft roll, whichever you like, but use thin layers of it rather than.
Okay, anyone has come across a problem of sore on the medial aspect of proximal thigh? Have you come across that? What do you do for that? Okay. Okay, good. Anything else? Okay, let me give you a very good suggestion that works very well. Apply a tegaderm. Tegaderm is a plastic film. So apply that on a medial side near the edge of the plaster, and it will not make the skin wet, and you will never get the problem of sore. So that's another practical tip I would like to add with you. Yeah, so like after, no. We keep it for 7 days. So we remove it, when we remove the plaster, we take out. We allow the skin to breathe for 15-20 minutes between the two plasters, and then we apply the new tegaderm. But the thing is, like, through tegaderm, the air goes. So it's not air-proof. It's waterproof, but air goes through that tegaderm. So now I request Hitesh, Sukalyan and Sandeep to demonstrate that technique.
So before we break, I've added Dhiren sir to the delegates group, so you can ask all the questions and everything, videos, everything directly also. And we'll have a group photograph, and then we'll go for the workshop.
Ready? Smile.
Yeah.
Okay.
नीचे है तो 4 फुट डोनेटेड है, ठीक है, इसलिए यहाँ पे केवस डिफॉर्मिटी है। तो ये केवस डिफॉर्मिटी करने के लिए क्या करना पड़ेगा, ये होता कि 4 फुट को जो है अपने को 2.5 फुट के लाइन में लाना है, तो इसलिए ये उठा के आप ये करेंगे। तो अभी ये जो लाइन है ये हील के लाइन में, लेकिन इसमें होता क्या है, apparently this gives a feeling that you are exaggerating the deformity.
One thing is, like, we need to allow the soft roll to come out on the toes, like this. So what I do, is like, the most experienced person should hold the foot. Plaster application is just a technician's job, but the most important thing is that he doesn't know where is the head of the terrace. So what we discuss is very true. Now once we